From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello, and welcome to this author interview from the JAMA Network. This is Dr. Adamson, the web editor for JAMA Dermatology. Dermatologists have a wide scope of practice, which includes medical, surgical, and cosmetic services. However, within the practice of dermatology, there exists significant confusion and inconsistency with respect to what treatments are considered medical versus cosmetic. In a viewpoint in JAMA Dermatology, authors outline several issues with how payers currently approach these determinations and outline a path forward towards more consistent coverage determinations across dermatologic conditions. Dr. John Barbieri is an assistant professor in the Department of Dermatology at the Brigham and Women's Hospital at Harvard Medical School, where he is also the director of the Advanced Acne Therapeutics Clinic. He is the lead author of this viewpoint, and he is here to discuss what constitutes cosmetic treatment and how that affects what gets covered for patients who seek care from dermatologists. Dr. Barbieri, welcome to the podcast again.
Thanks again for having me. It's a pleasure to be here.
You are somewhere different now. I think last time I interviewed you, you were at a different institution. Could you explain to the audience what your clinical focus is at Brigham and Women's Hospital? What do you study?
I joined the Brigham about a year and a half ago, and my primary focus here is research. I spend about 80% of my time working on epidemiology with a focus on acne, antibiotic stewardship, patient-reported outcomes, and health services research. And then the other 20% of my time is focused on clinical care and teaching and education. And I have a specialty focus on acne, and I run our acne clinic here at the Brigham and Women's Hospital.
Being someone that specializes in acne, was this part of the reason why you decided to write a viewpoint about what constitutes medically necessary or medical versus cosmetic dermatology?
As someone who takes care of a lot of patients with different chronic inflammatory skin diseases, whether they're acne, rosacea, psoriasis, vitiligo, hidradenitis, a theme I was seeing was that it seemed like some of the symptomatic aspects of disease were being considered medically important, but some of the important components of the lived experience, of the quality of life impacts of social isolation, depression, and stigmatization didn't seem to be considered as important to payers as the symptomatic components of these skin diseases. And it seemed somewhat inconsistent when you look at what things were and were not covered. And I thought it was something that was important to delve into further. In addition, a lot of the research I do is on patient-reported outcomes, which is really trying to capture what the patient's lived experience of their skin disease is. And we know from that work that many of these different skin conditions and aspects of them have meaningful effects on our patients' lives. And yet we were seeing that even though these skin conditions were having a meaningful effect, some were being considered to be medically important and some were being viewed as more cosmetic. And it didn't seem compatible with our patients' experiences and consistent with their experiences.
And I can imagine that a lot of dermatologists out there confront this on a routine basis. Say with acne, as an example, certain plans, say Medicaid in certain states, don't cover acne treatments at all. Other plans may stop at a certain age in terms of who they will cover for acne treatments. Do you have any sense of why these payers make the decisions that they make about what gets covered, when it gets covered, i.e. if it's someone under a certain age or above a certain age, et cetera?
One consistent theme I kind of noticed when thinking about this, when we were writing this, is that conditions where there's obvious symptoms, whether it's itching or pain, often it's more likely that something's going to be covered than when the main effects of the skin condition are not necessarily in the symptoms, but in the effects on that patient's life, whether it be through mental health impacts, through social isolation, through stigmatization, or other effects that maybe are more difficult to capture and consider for a payer. Like, for instance, rosacea, I think, is a great example of this. The bumps of rosacea, which often actually don't even have symptoms, but the bumps of rosacea, which can be painful, those often you can get treatments covered for them. But the redness and flushing that also characterizes rosacea, even though it can be accompanied by stinging and burning, is often very difficult to get any treatment covered for, even treatments that are generic. And that really struck me as something that doesn't really make sense in how our payers approach this common skin condition. In acne, which you mentioned, we often see payers will have restrictions based on age, or will have formularies that just either completely deny access to certain kinds of care and sometimes even all care for acne. And acne is a condition that has tremendous impacts on our patients' lives. It has one of the greatest global burdens of disease of any skin condition that we take care of in dermatology. And yet sometimes it seems like payers are marginalizing it as something that's not important to take care of.
Do you think some of it related to acne has to do with retinoids, as an example, that now are also marketed for their cosmetic effects in terms of helping with wrinkling or helping with reducing some dyspigmentation, and payers feeling as though perhaps too many patients are being prescribed this medication for that indication? Do you think that that's a potential issue there?
Yeah, I do think payers have a challenging situation with these medications that can be used both for what I think many people would view as medical indications and also for what likely many people would view as clearly cosmetic indications and trying to sort through that. And that's where it's important to have thoughtful prior authorization and clinical documentation practices. But if someone actually has acne, to me, that's a situation where it doesn't make sense that they have trouble accessing these treatments. 100%, I think it's important to think about a treatment that could be used for a cosmetic purpose and a medical purpose, making sure that the payer is considering which purpose it's being used for. I think that's fair and makes sense. But if someone really does have acne, and acne can persist into adulthood, 50% of women have acne in their 20s, 30% in their 30s, and even 10 or 15% in their 40s. It's important that patients are able to access appropriate treatments and often very inexpensive treatments for their care.
And in your viewpoint, you also touch on a few other disorders where I would say the actual symptoms of the disorder physically are minimal for the most part, but the psychological impact can be devastating. And those two disorders are vitiligo and alopecia areata. And with vitiligo, whose effects in terms of the psychosocial burden tend to be borne more on people that have darker skin types, there may actually be a disparity in terms of how people are being treated and having the medications to improve these conditions covered.
Yeah, those are great points. This is actually an area where there's really a dramatic lack of research and we need more data. But some of the data we do have is actually looking at vitiligo. So there was a 2021 study that looked across 65 different public and private payers and found that 12% did not cover topical calcineurin inhibitors, which are a fundamental treatment for vitiligo, and actually over half didn't cover phototherapy, which is another fundamental treatment for vitiligo, with the most common reason for denial in the study being that they considered vitiligo to be a cosmetic condition. But we know vitiligo can have a tremendous impact on our patient's lived experience, that it's an important thing to be able to treat and can be challenging to treat. So having access to appropriate treatments is critical. And alopecia areata is another example of a treatment that may not have a lot of symptoms such as itch or pain, but can have a tremendous effect on our patients' lives. And treatment can be so incredibly meaningful to these individuals. And it's another situation where it can be challenging to get coverage for treatments or for patients who are looking for something like a cranioprosthesis, like a wig, to help to manage their alopecia areata.
And I would also add a melasma there. In those cases, sometimes no treatment is covered for those conditions, and they may not have physical manifestations of the disorder in terms of itch or pain, but the psychosocial aspects are important, and dermatologists deal with that and see that every single day. So do you think the lack of coverage may be because as dermatologists, we haven't generated enough evidence and data showing just how harmful or how impactful having these diagnoses are to patients from a psychological perspective?
I think we do have some data from a quality of life standpoint that highlights the importance of these skin conditions to our patients and the importance of treating them. I do think we have a lack of data about treatments. A lot of these, for instance, disorders of pigmentation, we don't have many FDA-approved treatments for. I mean, having a JAK inhibitor, topical JAK inhibitor get approved for vitiligo is a tremendous advance in that area. So part of what may drive this is a lack of FDA-approved treatments where as a payer, you might say, well, everything's being used off-label, and so we don't want to cover that. But at the same time, there are many treatments that are FDA approved that still aren't covered and may even be relatively inexpensive generic treatments for these common skin conditions that do have meaningful impacts on our patients' lives.
And you brought up JAK inhibitors for alopecia areata. There also seems to be some pushback in terms of its coverage for alopecia areata if they don't actually demonstrate that they prevent other end organ involvement like thyroid disease.
Yeah, I think this again goes back to payers maybe sometimes not viewing the treatment of the skin disease as important in and of itself. I think sometimes we see this with narratives that happen in psoriasis, where we talk about the cardiovascular comorbidities and the importance of addressing those. But even just the psoriasis itself is important to address. Just that part of it alone is a reason to treat and help these patients. And I think sometimes payers don't totally see that. And I think we have to do a better job of generating data to show the effects on the lived experience of these conditions and the importance of managing them, and also developing new treatments that are FDA approved for these indications. But we also need to get support from payers and from other groups to help us define that these things are important and that they should be things that are covered.
So, our colleagues in plastic surgery have to also grapple with some of these same issues. What is cosmetic versus reconstructive? How can we learn from our plastic surgery colleagues on perhaps how to frame our treatments in such a way that they better understand the impact that they have on patients, or at least help us better define what is medically necessary versus what may not be?
Yes, I think plastic surgeons have a similar challenge that we can run to in dermatology, where the same treatment might be used in a reconstructive way and in a cosmetic way. And they have done a nice job of being proactive about it and crafting their own definitions to try to separate cosmetic from reconstructive by defining cosmetic surgery as focused around improving appearance as opposed to reconstructive surgery, which is focused around improving function. And this approach that they've laid out has been adopted by payers like the Centers for Medicaid and Medicaid Services to help guide coverage determinations. And I think we have an opportunity in dermatology to be thoughtful and to try to start to develop some of our own definitions of what is something that's cosmetic versus medical, to make sure that we're able to appropriately capture the importance of managing some of the different skin diseases that affect our patients.
Enhancement versus restoration. I think it is a good framework to think about some of the treatments that we do use that can do both.
I think that's a framework that we could try to think about in dermatology, where cosmetic treatments are focused around enhancement, whether that's trying to get rid of age-related changes, asymptomatic benign skin lesions, and medical treatments are focused around either alleviation of symptoms like itch or pain, or restoration of appearance to improve psychosocial functioning, whether that's flushing or dyspigmentation or scarring or alopecias that are causing issues with depression or stigmatization or other psychosocial challenges.
Is there anything you think patients can do to perhaps be involved in the process of helping decide what gets covered versus not, or dermatologists having more input in coverage determinations made by various payers?
Dermatologists absolutely have an opportunity to take advantage of some of the specialty organizations that we have and work within them and with them to start to develop formal definitions that we can try to codify and then use in efforts to lobby with Congress and Medicare and Medicaid, as well as with payers, private payers, to support a more consistent and equitable system of coverage for skin conditions. And then patients can absolutely become involved in this as well. There are plenty of disease-specific patient advocacy organizations and other opportunities for patients to be involved, because I do think this is a multifaceted process where we need to both work together within our field and with others and with our patients to think about this question of what is cosmetic and what is medical, and to clearly define those. And then once we've established those definitions, to lobby to Congress, to Medicare, Medicaid, to private payers to start to incorporate those definitions into their decision making. And then our patients and our researchers and our clinicians, we need to continue to work to build an evidence base about the diverse ways that these skin conditions can impact our patients' lived experience, and to develop innovative and effective treatments for some of these conditions that often I think get a bit neglected because there's such poor coverage that there's not interest in developing treatments. If you're a pharmaceutical company and you know no one's going to cover the treatment you make, you're not that excited about developing it, even if there might be great opportunities and pathways and drugs to explore.
I want to thank you, Dr. Barbieri, for this insightful discussion. This is Dr. Adamson, web editor for JAMA Dermatology. This episode was produced by Shelly Steffens at the JAMA Network. The audio team here includes Daniel Morrow, Lisa Hardin, Audrey Foreman, Mary Lynn Ferkaluk, Hannah Park, and Dr. Linda Brubaker. To follow this and other JAMA Network podcasts, please visit us at jamanetworkaudio.com. Catch you on the next episode of the JAMA Dermatology podcast.